Clinically, a premature or preterm infant is defined by a single metric: birth occurring before the completion of 37 menstrual weeks of gestation. This timeline dictates the diagnosis, completely regardless of the infant's birth weight. This scatter plot illustrates why weight is a flawed proxy for prematurity. By plotting gestational age on the x-axis against birth weight on the y-axis, we separate the duration of the pregnancy from the physical mass of the fetus. When we map the data points across the 10th to 90th percentiles, we establish what is considered appropriate for gestational age, or AGA. Infants falling below this channel are small for gestational age, and those above are large. A baby born at 32 weeks can perfectly track within that middle AGA channel, possessing normal physical growth potential for its specific age, while still being dangerously premature. Drawing a hard threshold at 37 weeks visually separates healthy, mature term births from the preterm zone. Everything to the left of this line falls into physiological jeopardy. An infant born on the left side of that line might weigh a normal amount for its age, but the clinical threat isn't a lack of mass. The danger lies in profound functional and structural immaturity across almost every major organ system. Examining the macroscopic anatomy reveals the severity of this immaturity. The skin of a preterm neonate is exceptionally thin, red, and shiny. Because the infant lacks any insulating layer of subcutaneous fat, the superficial vasculature is directly visible through the skin. The exterior surface is covered by a plentiful layer of fine hair called lanugo, and the waxy coating known as vernix caseosa. Further down the body, the deep plantar creases typically seen on the soles of the feet are entirely absent before 34 weeks of gestation. The cranial proportions are equally unformed. The skull bones are soft, separated by wide sutures and an exposed posterior fontanelle. This results in a head circumference that disproportionately exceeds the circumference of the chest. These external deficits are clinical indicators. They reflect internal cavities housing deeply unformed organ systems that are entirely unprepared for the physical and metabolic demands of existing outside the uterus. For infants born before 34 weeks, idiopathic respiratory distress syndrome, or RDS, stands as a primary cause of mortality. This 3D cross-section of a healthy, full-term alveolar sac demonstrates normal respiratory mechanics. A fluid layer composed of pulmonary surfactant lines the interior, actively reducing surface tension and allowing the sac to remain open and inflated during exhalation. The preterm lung lacks this essential surfactant. Without it, surface tension spikes rapidly. Upon exhalation, the structural walls of the alveolus pull inward, causing complete mechanical collapse, a condition known as pulmonary atelectasis. When this collapse occurs simultaneously across millions of alveoli, gas exchange halts. The infant experiences immediate hypoxia, triggering a compounding cycle of severe metabolic acidosis. As the lung tissue starves for oxygen, the structural integrity of the pulmonary system degrades further, frequently resulting in secondary fluid buildup, pulmonary edema, and direct intraalveolar hemorrhage. Preterm respiratory distress is a mechanical failure of surface tension that initiates systemic metabolic collapse. Within the neurological system, cerebral hemorrhage threatens the preterm infant through two distinct biomechanical pathways, one structural and one physiological. The first pathway traces back to the uncalcified anatomy of the infant's skull. The soft bones and wide sutures are designed to allow for passage through the birth canal, but they offer minimal resistance to external force. During a routine delivery, an excessive degree of molding laterally compresses the cranium. This shear stress translates directly into the cranial vault, severing vessels and causing massive subdural or subarachnoid hemorrhage. The second pathway originates deep within the interior structures of the brain, specifically within the subependymal capillary network. These specific microscopic vessels are severely fragile in preterm infants. They cannot withstand even minor fluctuations in blood pressure or brief periods of hypoxia. The vessel walls quickly distend and rupture, flooding the ventricles in what is known as an intraventricular hemorrhage. The preterm brain injury is the direct consequence of a skeletal shield failing to protect highly vulnerable microscopic vasculature. This split-screen clinical heat map contrasts the thermal regulation of a term infant on the left with a preterm infant on the right. The preterm body has an abnormally high surface area to mass ratio and lacks both subcutaneous and brown fat. The result is catastrophic, unchecked heat loss. To compensate for this rapid hypothermia, the infant's body shifts to anaerobic metabolism. This desperate attempt to generate heat only deepens the existing hypoxia and drives up acid levels in the blood. Simultaneously, the hepatic system begins to fail. The immature liver lacks stored glycogen, which abruptly drops the infant's blood glucose below 40 milligrams per deciliter, inducing severe hypoglycemia. The liver also fails at conjugation. It cannot process the excessive bilirubin produced by the normal breakdown of red blood cells. Unconjugated bilirubin builds rapidly in the bloodstream, leading to clinical jaundice. Finally, the immature nephrons of the kidneys are entirely incapable of filtering water, solute, or acid loads. The infant quickly develops oliguria and anuria, halting urine production and precipitating abrupt, life-threatening dehydration. The preterm physiology operates without energy reserves, chemical filtration, or thermal insulation. Without aggressive clinical support, metabolic homeostasis is impossible. Arresting this cascade of hypoxia requires clinicians to administer high concentrations of supplemental oxygen, often exceeding 40%. However, this necessary intervention introduces severe iatrogenic risks. The most prominent is retinopathy of prematurity, a multifactorial disorder responsible for a high percentage of childhood blindness. Looking at this schematic of a developing retina, prolonged exposure to high oxygen concentrations derails normal vascular growth. The oxygen triggers abnormal neovascularization, chaotic, dense networks of fragile blood vessels that overgrow the retina, eventually scarring and detaching it. It is a severe clinical paradox. The medical interventions required to save a failing pulmonary system often carry inherent toxicity for equally immature secondary systems. Because every complication of prematurity is tethered to anatomical underdevelopment, managing idiopathic preterm labor is an exercise in tactical delay. The goal is rarely the permanent arrest of labor. Clinicians deploy tocolytic agents, using drugs like nifedipine or atosaban, to pharmacologically inhibit uterine contractions by relaxing the smooth muscle fibers of the uterine wall. These drugs are administered to buy a tightly defined 48-hour window before the inevitable expulsion of the fetus. Within this window, the first critical intervention is administering glucocorticoids directly to the mother. This steroid therapy crosses the placenta and aggressively forces fetal lung maturation, drastically increasing the baby's internal production of pulmonary surfactant. The second intervention involves dosing the mother with magnesium sulfate. This acts as a fetal neuroprotector, specifically deployed for deliveries before 34 weeks to reduce the incidence and severity of cerebral palsy. Modern obstetric management relies on this active biological manipulation, using pharmacology to force the rapid maturation of vital organ systems inside the uterus before time runs out. When labor inevitably progresses, the delivery mechanics must be tightly controlled. The birth is managed slowly and gently to avoid the rapid cranial compression and decompression that shears cerebral vessels. Immediately upon delivery, the umbilical cord is quickly clamped. This prevents hypervolemia, an overload of blood volume returning from the placenta, which would exacerbate jaundice. The neonate is instantly transferred to intensive care protocols. Airways are cleared of mucus, strict thermal limits are imposed to block anaerobic metabolism, and oxygen is carefully titrated to the lowest effective concentration to mitigate the risks of retinopathy. The management of a premature neonate demands constant physiological calibration. Clinicians are attempting to synthetically bridge the severe gap between an unfinished anatomy and the immediate, unforgiving metabolic demands of independent life.